So I'm not sure, do you all just see the slides or you see the entire presentation mode?
We can see the presentation. So now I can see there's the one slide and I can see the next slide that's coming up as well.
Oh, okay. Let's see. Okay, so just, okay. Where we got it. Okay, so I'm here today. I'm going to do a brief SBIRT training. I'm pretty sure most people have heard of SBIRT, but don't know the full details of SBIRT. And so this presentation is on screening, brief intervention, and referral to treatment, also known to most as SBIRT. Okay. So some learning objectives that we'll focus on today is what is SBIRT and why use it, the screening for substance use disorder, the brief interventions and referral to treatment, and we'll also go over a couple of scales, screenings. So what is SBIRT? So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. It is an evidence-based approach used in healthcare settings, particularly primary care, to identify and intervene with individuals who are at risk or have had issues with alcohol or substance misuse. So why use SBIRT? So SBIRT is designed to be adaptable to various healthcare settings and can be implemented by a range of healthcare professionals, including physicians, nurses, and behavioral health specialists. It focuses on early identification and intervention, makes it a valuable tool in addressing substance use issues at an early stage. So what are some of the goals of SBIRT? So it's for prevention, early intervention / treatment, comprehensive approach, and engaging individuals in treatment. So with prevention, you are identifying and addressing risky substance use before it leads to more severe problems. With early intervention, you're offering timely intervention for those at risk or in the early stages of substance use issues. The comprehensive approach is taking a holistic and integrated, I'm sorry. Ooh, Jesus. Okay. Taking a holistic and integrated approach to address public health concerns related to alcohol and drug use and engaging individuals in treatment for those who meet the diagnostic criteria for substance use disorder. The aim is to help them enter and remain in appropriate treatment programs. Am I still in presentation mode, Gloria?
No, it did switch back.
Okay.
Yeah, but we can still see the screens.
Okay. Play from current slide. Is it in presentation mode again? Can you
Yes,
see?
yes, we are back in presentation mode.
Okay, so you only see one screen.
I can still see the next screen coming up, but yeah, it's in presentation mode.
Okay, sorry, I don't know what is going on with this. Okay, you know what? We'll just keep going. Sorry.
That's okay.
So we went on that. Sorry, next slide. So why implement SBIRT? So according to SAMHSA, these are some statistics that I received from SAMHSA. It reduces healthcare costs. So saving range from $3.81 to $5.60 for each dollar spent, 20% fewer ED visits, 37% fewer hospitalizations, 46% fewer arrests, and 50% fewer motor vehicle accidents. So it decreases the severity of drug and alcohol use. SBIRT supports overall wellness, and late-stage intervention can be expensive and lead to increased comorbid conditions. So waiting late, we can get jail time, paying fees. So SBIRT is like a way of alleviating those things and motivationally trying to deter someone from continuing the use of substances. So the breakdown components of SBIRT, we know the S is for screening, the B and I is for brief intervention, and the R and T is referral to treatment. So screening is the first step, involves the systematic screening of all individuals for risky or harmful alcohol and drug use. The screening is typically brief and can be incorporated into the routine healthcare assessments. The brief intervention, if the screener identifies a person as being at risk, a brief intervention is conducted. This is a short motivational conversation that raises awareness about the potential consequences of substance use and encourages the individual to make a positive change. And referral to treatment is for individuals with more severe substance use issues, or referral to treatment may be necessary. This step involves connecting a person with specialized services or resources for further assessment and treating. So we'll start with universal screening. That is the first. Universal screening is recommended for all adult patients ages 18 or older at least once a year. Repeat screening at various intervals are suggested to assess patients' progress and identify changes in alcohol use patterns. Identification of persons. Universal screenings help identify patients who may require a more in-depth or full screening process. And then in a primary care setting, the screening process can be administered by the receptionist using various methods such as paper forms, tablets, or kiosks in the waiting area. And in an emergency department, universal screening can be conducted through a verbal interview by a nurse during the triage process.
I have a question, Deanna.
Uh-huh.
So for this screening process, someone will only use it if they thought that the individual was suffering from substance use disorder, like maybe just by asking a series of questions, or
Yeah, so it's the audit and DAS. It's like sometimes they are incorporated in the ED triage. When you go in, they ask like a question, and if you answer yes to that question, it triggers for them to alert other like social workers. I know at Rush, it starts in the ED. You do an assessment with the nurse. If you answer yes to that question, it triggers for the nurse to contact the social worker that'll come bedside to that person.
okay, okay. Thank you.
You're welcome. And then,
Question.
sure, go ahead.
Hi there. Daniel Mendez, nice to meet you. Apologies for
Hey, how are
getting.
you? Thanks for coming.
Yeah, of course. So with those in the ER, so let's say they enter the question and they're going to be assessed by a social worker. Is that something to where a client may opt out? Is that something that is then required for them to wait for?
Oh, no, all, in healthcare, you can opt out. So yes, they can opt out if they don't want to be treated, if they don't want to see the social worker, if they don't want the bedside treatment, if they don't want the referrals, they can opt out. A lot of people do just get the treatment in the hospital and leave. They don't get like the referrals and things of that. And so that's why it's being started in the ED to try to get the motivation to help them to get to the next step, get the treatment, get the referral, kind of, in a sense, hold their hands to each step. So like a warm handoff. So with screening, did that answer your question? I'm sorry. Thank you. So in the administration part, you check in, you're rooming, and then in an advanced appointment, someone may know that they can receive these services and they may call for it in advance appointment to just come in. And some of the common assessments are the alcohol use disorder identification test, which is the audit, the drug abuse screening test, which is the DAS, and then there's the NIDA modified acid. And then the CAGE and the CRAFT. The CRAFTS is more for adolescents. I think the CAGE is as well. So the screening process, if low risk, so say you answer no, there's no further intervention. You just want to continue to congratulate them on being abstinent from using substances or drinking and just let them know, hey, you're good to go. Moderate risk, you may have a brief intervention. Moderate to high risk, you will have a brief treatment. And then severe risk and dependency, it will be referral to specialty treatment. And then we'll get into some of those treatments on the next slides. So the brief intervention, percentage of patients requiring intervention or treatment can range from 5 to 20%. Brief intervention educate and increase motivation to reduce risky behaviors. So usually 1 to 5 sessions lasting 15 to 20 minutes, and 15% of patients receive a score indicating need for brief intervention. And for brief treatment, you change the immediate behaviors thoughts about risky behaviors. So that's usually 5 to 12 sessions, lasting 5 to 20 minutes, and 3% of patients receive a score indicating need for brief treatment. Sorry. So brief intervention activates what we like to call motivational interviewing or building your rapport. So you want to build rapport by asking permission and raise the question. So I appreciate you answering our health questionnaire. I'd like to take a few minutes to talk about your results. Is that okay with you? Then you want to tell me about a typical day in your life. Where does your current alcohol/drug use fit in? Brief intervention also activates and discuss pros and cons of continued use. So you want to ask, like, help me understand through your eyes the good things about using alcohol and drugs, and what are some of the not so good things. So on one hand, you have the pros, and on the other hand, you have the cons, and they can see how that one outweighs the other. You also want to provide personalized feedback. I have some information on low-risk guidelines for drinking/drug use. Would you mind if I shared them with you? And then just let them know, like, so many drinks a day can result to this, and so many drinks a day or so many uses of substances a day can put you in particular categories and where you will need intervention or treatment or referral to a specialty. And then you want to evaluate their readiness to change, and you want to support an action plan and discuss a plan for change. The brief intervention also activates the readiness ruler. So on a scale of 1 to 10, the readiness ruler is also like the pain scale that's used. So on a scale from 1 to 10, with 1 being not ready at all and 10 being completely ready, how ready are you to make any changes in your drinking/drug use? Why did you choose that number and not a lower number like a 1 or 2? That's if they chose a higher number, you kind of want to gauge, well, why are you this high and why aren't you this low? So then on a scale of 1 to 10, how important is for you to decrease or quit drinking/drug use? And then on a scale of 1 to 10, how confident are you that you will be able to make these changes? Brief intervention also activate OARS, OARS, which helps to engage and leads patients into self-motivational statements. So like open-ended questions, affirmations, reflective listening, and summarizing. So brief intervention also activates DARN CAT. So this is change talk. So DARN stands for desire, ability, reasons, and needs, and CAT stands for commitment, activation, and taking steps. So the D is desire, a wanting, wishing, or willing. So do not express specific reasons, only a general level of desire. So I want to, I wish, I hope. And then ability is the personal perception of capability or possibility to change. So I can, I am able to, I could do it. Reasons specify a particular rationale, justification, or motivation for making change. So if I stop drinking, then I won't lose my job. If I stop drinking, then I'll have more friends or more family members will be tolerated with me. Needs is necessity, urgency, or requirement for change. I need, I must, I can't. And then we get to CAT, commitment, activation, and taking steps. So commitment is I'm prepared, I'm going to, I swear. Activation is I'm ready to, I plan to, so taking steps towards the change. And then taking steps, I got rid of the alcohol in the house. So that's a particular action taken that moves towards the change. And then we also have goal setting. So you want to provide rationale for setting goals. So if you identify what you want to change, we can take steps to work on that. They also elicit desired outcomes. So they'll list the things that they want to get out of their appointments when they're meeting with you. Want to be specific about the goal. So what is the target goal and what is the patient's role? And then you want to state goals in a positive manner. You'll have them list some things they want rather than what they do not want. And then you want to define behaviors related to the goals and what does it look like when you are using substance versus when you are not using substances. We also have the ABCs, so the antecedents, the behaviors, and the consequences. People, places, feelings, etc., that occur before the behavior. Behaviors, what behaviors occurred as a, oh my goodness, as a result of the antecedents, and consequences. What positive attitudes were the response to the behavior? And then most cases you will end with homework. So readings, behavior monitoring, or practicing skills should be given, help to facilitate skill acquisition, treatment compliance, and symptom reduction. Now we are on to the last part, which is referral to treatment. So the referral to treatment phase in the SBIRT process involves providing feedback to individuals based on their screening results and encouraging them to engage in specialty care if needed. So you'll start with feedback and recommendations. You'll provide clear and understandable feedback to individuals regarding their screening results. You'll make recommendations based on the severity of their alcohol or substance use, guiding them towards appropriate levels of care. We'll explore motivation using motivational interviewing techniques as discussed in the previous slides, to enhance the individual's motivation to engage in specialty care, understand their perspective, concerns, and willingness to make changes. You want to increase participation and retention. So you want to utilize the motivational interviewing again to increase participation and retentions in the treatments. And you want to address ambivalent and enhance the individual's commitment to change. You also want to maintain engagement, so develop strategies to maintain engagement for individuals who may be hesitant or resistant to entering treatment, and you want to provide ongoing support and encouragement. We also like to do linkage to specialty care, so that ensures appropriate linkage to specialty care is facilitated, taking into account the specific needs and preferences of the individual. You want to coordinate with relevant treatment providers and service. And then coordination of continuity of care, timely and appropriate coordination of care is crucial. You want to ensure a seamless transition from the screening and referral process to specialty care. And you want to foster continuity of care to enhance the effectiveness of the treatment. And then we have warm handoff, which is implement a warm handoff as a best practice. This involves a direct in-person introduction and transition from one healthcare professional to another, and it enhances communication between the referring and receiving parties to facilitate a smooth transition. And lastly, we want to identify and problem solve any barriers. Oh my goodness, my watch is talking, sorry. Work collaboratively with the individual to identify and address any barriers to treatment participation. And then you want to provide support in problem solving and overcoming any obstacles. So overall, the referral to treatment phase is a critical step in helping individuals move from identification of substance use issues to receiving the appropriate care that they need. So effective communication, motivational techniques, and a patient-centered approach are key elements in this process. So we're going to look at some of the screening tools that are used for SBIRT. And we have the NIDA Quick Screen, and all of these screenings are from NIDA. So this is the NIDA Quick Screen. And if a patient says no for all drugs, you reinforce abstinence and screening is complete. If yes to 1+ days heavy drinking, you want to start brief intervention. If yes to use of tobacco, you want to advise all to quit. And if yes to illegal drugs or prescription drugs for non-medical reasons, you want to proceed to the NIDA Assist. And then that's this screening, which is 8 questions. So in your lifetime, which of the following substances have you ever used? And it just lists the different substances, cannabis, cocaine, and so forth. And so if a patient answers yes to any of the drugs, you want to proceed to questions 2 through 8 to determine the level of risk. And so this is the NIDA-assist scoring. So if you're high risk, we'll provide feedback on the screening results. We'll advise, assess, and assist, arrange referral after continuing support. If it's moderate risk, which is a score of 4 to 26, we'll provide feedback, advise, assess, and assist, consider referral based on clinical judgment, and offer continuing support. And if it's lower risk, we'll provide feedback and we'll reinforce abstinence, and we'll also offer continuing support. So that's the asset scoring. And so now we'll move to the DAS, and DAS is what's typically in, like, if you go into the ED, the question that they'll ask and the one that'll trigger like a nurse or social worker for more reinforcement. So they'll ask, in the past 12 months, have you used drugs other than those required for medical reasons? If yes, then that indicates a full screening needs to be done. And then this is the full DAS screening that'll be done while the person is either in the ER, at their primary care physician, or wherever it is that they are getting this screening. They'll go through all of these questions. What recreational drugs have you used in the past year? It'll list those drugs, and the patient can say which drugs it was. And then there's additional questions like, have you used drugs other than those required for medical use? Do you abuse more than one drug at a time, and so forth. And then there's a scoring, the DAS scoring. So it's 1 point for each yes response. And then it shows the different scores and the different risks. So if you're 0, you're low risk. If you're 1 to 2, you're risky. 3 to 5, you're harmful. And 6 to 10, you're severe. So the brief interventions again are 5 to 20 minutes, not 15. And the brief treatments are 15 to 60 minutes. And you focus on the brief intervention is to enhance motivation for the patient to accept referrals to specialty treatment. So after that, we're hoping that they're going through the screening, they got their assessment, and we're warm-handing them off to their specialty treatment. So then this is the audit screen. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day of drinking? How often do you have 5 or more drinks on one occasion? So the audit is more so alcohol. And then these are more questions for the audit. Hope I put the screening in. Yes, I did. And then I put the scoring in, which is 0 to 3. Low risk, 4 to 9, risky, 10 to 13, harmful, and 14 or more is severe. And so this slide is a slide that we put in all of our presentations. It's just how to get substance use help, the Illinois helpline, the adult line, and also a resource for teens and pregnant individuals at Lawndale Christian Centers. And then if you have any questions or are interested in any of the other presentations that we offer, you can ask those now.
I do have a question, Deanna. So just because I did get a little bit confused. The SBIRT training is the SBIRT, it's a screening tool. Is it a screening tool just like the last few tools you mentioned? Is it just one option? Because you mentioned the NIDA, the DAS, and the audit. So are they all just different kinds of screening tools, or
Right.
does the
Yeah.
SBIRT lead you into the other tools?
So the Those tools are part of the SBIRT in the whole. So those are the tools that are used for the screening
The NIDA, DAS,
and
and they're
audit.
part of SBIRT?
Uh-huh.
Oh, okay. Okay. Got it. I was just a little confused. Thank you.
Oh, no, that's fine. Daniel, any questions?
No question. Actually, yeah.
Okay.
Sorry. When let's say somebody is what was it? I think like medium or high risk, like the two in the middle.
Okay.
Excuse me. What does the like wait time look like for, say, a patient who says like, you know what, great, I want to talk about this.
Huh.
I'd love for somebody to follow up with me. So what does it look like when they're in between either appointment times, referral, just from leaving the ER to getting their next point of service?
Okay, so in the ER, after they're screening, and it's triggered that a social worker, someone in substance use needs to come bedside, it's almost immediately that that person is to come bedside to talk to them, to start the motivational interviewing and to start the next steps of the process that they will be going through. So once they're bedside, they'll talk to the social worker, they'll be treated bedside as well for whatever substance or that they need to be treated for. And then in that process, they'll be working on referrals. So the social worker will come back to bedside like, hey, I found these programs or I found these resources that may be useful for you. Would you like to set some of these things up? So all of these things are being set up bedside, and hopefully it turns into a warm handoff where you can take that patient and you can hand them off to the specialty resource or doctor that you have found for them. And that's the steps and hopes of how we would like to see it go, but it doesn't often go that way. So sometimes there may be a wait time, and then we may lose people because they're tired of waiting and they just leave.
Okay, and will they be like are they able to follow up? Is
Oh,
it
yeah.
like yeah?
In
Okay,
most
so
cases, either the social worker will try to follow up with them, especially if they leave, because no one wants to see anybody just abruptly leave, because you know something's gonna possibly go wrong, or you're gonna see them in the ED again.
okay, great, thank you. Yeah, it sounds excellent. Just yeah, I know those.
Yeah, it sounds good, but it's so hard, the process of getting
That's
people
just
figured
humanity. We have to
out.
deal with those things.
Yes, correct. So, MOUD and the ED has been a bit frustrating because, and then even on the provider side, we get a lot of pushback from nurses and social workers. They don't want the extra work. It's a lot,
Mhm.
but it's useful. It's helping. It's decreasing numbers. It's decreasing hospital visits. Yeah.
Yeah, absolutely. And I appreciate just providing that service for folks as a way to it doesn't alienate them.
Sorry, I just didn't want my Zoom to go out. It's been acting up, so if I get to doing multiple things, it'll just shut down. But thank you guys for listening to my presentation today, and I hope it was useful.
Thank you. It was very useful.
And
Thank you.
I'll just get everything rolling for our next session and hopefully get those emails out early so we can have more participants.